Chapter 28, The Woman with a Postpartum Complication. Postpartum hemorrhage is generally defined as a blood loss greater than 500 ml for a vaginal delivery and greater than 1,000 ml for C-section. Hemorrhage in the first 24 hours after birth is called early postpartum hemorrhage, and anything from 24 hours after birth up to 12 weeks is called a late postpartum hemorrhage. An early hemorrhage usually will occur within the first hour after birth and is most commonly caused by uterine atony. Atony is a lack of muscle tone, so uterine atony is when the uterus won't stay contracted. Remember, it must stay contracted and firm or a postpartum hemorrhage can occur. Some predisposing factors for the uterine atony include overdistension of the uterus, obesity, a prolonged labor with ineffective contractions, a precipitate labor, medications to induce or augment labor, mag sulfate, and C-section delivery are some of them. Therapeutic management include all patients to receive oxytocin after delivery to help with that involution process. This is given either IV or IM. Frequent fundal checks are needed to assess uterine atony. If the fundus is boggy, we must massage it until it firms up. If the fundus does not become firm or remains firm or will not remain firm after massaging, the cause could be a full bladder. When the bladder is full, it pushes the uterus over and then it's not able to contract effectively to keep it firm. If mom is stable, she may get up to void, but if heavy bleeding is occurring, a cath should be used to empty the bladder. If these measures do not work, additional medications are needed. Misoprostol or Cytotec many times is the first drug of choice. It is a synthetic prostaglandin which promotes uterine contraction. Your book states you can give it orally or sublingually, but many times it's used vaginally or rectally and works very quickly and well. Methogovine or Methergin is also a medication that can be used. It is given IM, but it can cause hypertension, so it should not be given to a woman if she's hypertensive. Another medication is carboprost, trothrobrine, or Hemavate, given IM. The bad thing about that medication is almost always it will cause nausea and diarrhea and should not be used for a woman with asthma. If these measures don't work, the provider may do bimanual compression of the uterus, where one hand is placed inside the vagina and the other on the outside of the uterus, massaging. They may also try using what is called a Bakri balloon catheter that they just insert into the uterus, inflate the balloon, which will cause the uterus to stay firm and decrease the postpartum bleeding. If all these measures are unsuccessful, they have to do a hysterectomy. If the postpartum hemorrhage is due to trauma, it can be caused from trauma during birth, which could cause a hematoma, or another cause can be a laceration that was not sutured. Small lacerations do not require sutures. If a woman is bleeding and her fundus is firm, you should suspect a laceration and you need to contact the provider. None of the interventions for uterine atony will work. See Table 28.1 for nursing assessment for that postpartum hemorrhage. The most common cause of a late postpartum hemorrhage is subinvolution and retained placental fragments. Some predisposing factors include the providers trying to deliver the placenta before it separates from the uterus wall, manual removal of the placenta, placental accretia are a few. Therapeutic management includes controlling the bleeding. This can be done with medications we discussed earlier. If this is successful, then no further treatment is needed. If it does continue, she may need a D&C. Broad-spectrum antibiotics will be given if postpartum infection is indicated. Most women can compensate for normal blood loss during the birthing process. Bleeding that is excessive that can lead to hypovolemic shock, hypovolemia, which can turn to hypovolemic shock. This is due to the decreased blood volume circulating and less going to each body system, causing major problems. Early signs of blood loss include tachycardia or hypotension, but typically do not show up until 25 to 30% of our blood volume is gone. Tachycardia tends to be one of the earliest signs. The respiratory rate will increase as she becomes more anxious. Vasoconstriction happens as the body is trying to compensate by hanging on to all its blood volume. That vasoconstriction will cause her to become pale and the skin cool. As the shock worsens, she'll become more anxious, confused, and lethargic. Urine output will decrease as well due to very little blood being circulated to the kidneys. The goal is to control the bleeding. We need to find the source so we can stop it. A second large bore IV to be started for large volumes of fluid that will be given so we can get a minimum of 30 ml an hour of urinary output. Vasopressors may be given to try and increase the blood pressure. Nursing considerations include that all units have measures in place when a postpartum hemorrhage occurs. Most units have a hemorrhage kit or cart that has everything in it that they need. It's kind of like a crash cart for obstetric bleeding emergencies. Nursing care for the patient with excessive bleeding puts all of those things together that we just talked about. Many times there's no warning that a postpartum hemorrhage is going to occur, so frequent assessments are needed, and noting even subtle changes can help prevent major complications that can occur with a postpartum hemorrhage. You should always take time when you come on your shift to look at your patient's chart to see if they have any risk factors for hemorrhage. Knowing that a patient does makes you much more aware of those little changes and keeps us on our toes with the assessment process. When assessing for bleeding, you will massage the fundus and check to see if it's firm, the location, and also if she's bleeding while massaging. Remember, if she's laying in the bed, that blood can pool up and under her back, so having her roll so you can see. If a woman still has anesthesia in her system, she may not be able to feel that excessive bleeding, so you must check. If her fundus is boggy, massage and assess for bladder distension. If she is firm and bleeding, think laceration. If you are the least bit concerned about bleeding, notify the provider so they can check. Early interventions can prevent major complications if the blood loss goes undetected. Interventions can include medications to contract the uterus if that uterine atony is the cause. Anytime someone has excessive blood loss, they have less ability to carry oxygen throughout their body, so we want to conserve their energy. Having the woman rest and place oxygen on her are interventions you can do. The patient or family can become very anxious, so keeping them informed on what is happening is crucial. Do not hesitate to call a rapid response for more help if needed. If a large amount of blood has occurred, the provider will order labs to monitor hemoglobin, hematocrit, platelets, so they have a baseline. Another intervention may be preparing for blood transfusions if the loss is great. Subinvolution is slower than expected process of the uterus returning to its pre-pregnancy state. It typically descends about 1 centimeter or 1 finger breadth per day, and by day 14 postpartum, it cannot even be palpated above the symphysis pubis. The most common reason this happens is retained placental fragments. Therapeutic management includes correcting that cause. Methogen is given to help keep the uterus contracted. If there is an infection, antibiotics should be ordered. Nursing care includes educating the patient on the signs to report to the provider, as many times this is not noticed until the patient is already home. We also teach the progression of lochia. It starts out as rubra, changes to serosa, and ends with alba. A patient should never go backwards in this. If she was at serosa, she should not go back to having rubra. If so, she needs to contact her provider. Any pelvic pain, fundal pain, or pelvic pressure needs to be reported right away as well. The major cause of thromboembolic disorders is the superficial venous thrombosis, deep vein thrombosis, and pulmonary embolism. Remember, during pregnancy, the legs can experience venous stasis when standing for a long time. They are in a hypercoagulation state during pregnancy, which puts her at risk for clotting problems, and she can have vascular damage from trauma during birth. SVT is most common associated with varicose veins and is generally found in the calf area. It could also occur in the arm from IV therapy as well. You may be able to palpate a large, hard, cord-like vein. Treatment includes rest, analgesics, elastic support. Signs and symptoms of DVT are absent in most women. If they have symptoms, they will include pain in the legs or groin. Swelling in the affected area can occur, with also color change and changes in the temp. All new moms are encouraged to ambulate frequently to help prevent DVTs. Compression stockings will be ordered if she will remain in bed for longer periods after a C-section. Anticoagulant therapy will be started with the presence of a DVT. A pulmonary embolism many times does not have signs and symptoms as well. Dyspnea, chest pain, tachycardia, tachypnea are the most common signs you may see. Treatment is geared at dissolving the clot. Oxygen will be given Bed rest ordered with the head of the bed elevated. Analgesics may be given for pain and monitoring the vitals, including the pulse ox.